Welcome to our National Fellow Online Lecture Series. This is a series that's sponsored by our Fellows Online Educational Subcommittee through AMSSM, which is the subcommittee of the Education and Fellowship Committees. Next week, we have Online Fellow Lecture Series with it's part of our MRI series. So foot and ankle, and Dr. William Walter will be talking about all the various things that we need to know about and going through it in detail. Our moderator will be Dr. Haruki Ishii. And as usual, it'll start at 8:30. Tonight, we are lucky to have Dr. Shane Miller, who will be here to talk about physeal injuries. I'm going to do a little intro to him in a moment, but first, let's talk about the goals of this series. It's an adjunct to home programs, educational programs. We want to provide fellows with direct access to educational experiences with different AMSSM members and at times invited guest experts. It's really designed to assist in the CAQ exam prep. So we want your input. We want to make sure that the things that we cover are relevant to the CAQ and relevant to what you feel like you need to study more. So please give us topic suggestions and ideally some speaker suggestions so that we get those from throughout the country in different specialties. There are different ways to give some suggestions. One is the website, amsssm.org, under Education Fellows Online Lecture Series. You'll see a prompt there to take you to the suggestion page. Also, you can use the QR code. Remember that the primary goal is to assist in CAQ preparation. So Dr. Miller is from Scottish Rite down in Texas, and he is a pediatric specialist. He completed his medical school and residency training at Baylor College of Medicine and Texas Children's Hospital, Houston. He then went on to complete a pediatric sports medicine fellowship at University of Colorado and Colorado Children's Hospital in Denver. He's the section director of medical sports medicine at Scottish Rite for Children and professor of orthopedic surgery and pediatrics at UT Southwestern Medical Center. He was elected executive committee of the American Academy Pediatrics Council on Sports Medicine and Fitness, and currently serves as a team physician for the Dallas Stars NHL hockey team, various local high schools, and numerous sports organizations. Welcome tonight, Dr. Miller. Please, if you have any questions, put them in the chat, and I will make sure to attend to them at the end. And of course, I believe if you have any pertinent questions that you need to sort of speak up, just sort of raise your hand in the event.
Perfect. Thank you, Dr. Goldberg, and thanks to AMSSM for hosting this ongoing education series. I'm excited to be part of it tonight. Thanks to those of you who are joining us online this evening live, and as to those of you who will be watching it at a later date. Hopefully this will provide a good review for you, as Dr. Goldberg said, for the CAQ. And certainly for those of you who may not see a lot of pediatric patients during your fellowship or in your practice, will help prepare you to take care of some of the younger athletes that you may come across after completion of your fellowship. I have nothing to disclose. We're going to review starting with the anatomy of growing bones, and then we're going to talk primarily about acute injuries, making sure that we can recognize some of those acute growth plate injuries in young athletes, and then moving on to how to manage some of the more common growth plate overuse injuries. Certainly see both acute and overuse injuries in this population. So we'll start with talking about what is a growth plate. The physis itself is the growth plate, and we're going to go in a little bit more into the anatomy of that in detail a little bit after this, but just so reviewing some of the terminology. The physis itself is the growth plate. The epiphysis is the part that's adjacent to the articular surface or to the joint, and is sort of the longitudinal growth center. And then you have the metaphysis, which is the portion that widens, kind of is cone-shaped and coming close to the physis itself. And then the diaphysis is the shaft or the longer part of the bone. You also have an apophysis or apophysis as opposed to epiphysis, which is a little bit more of a traction center and adds shape or contour to a bone. And we'll talk a little bit about both the epiphyseal and apophyseal injuries as we move forward. So the growth plate itself it has some interesting anatomy, which helps us understand these injury patterns a little bit better. When we're looking at the epiphysis, there is an epiphyseal artery adjacent to the articular surface, which is important for blood supply. And right next to the epiphysis there is a resting layer of what we call the germinal layer, the germinal zone. It's basically where our stem cells that are waiting to grow into the growth plate are sitting. And then they start to line up a little bit into the proliferative zone. That's where replication and growth starts to occur. And then they start to hypertrophy. The cells are increasing in size and their columnar formation being ready to be calcified. So this is the area, the hypertrophic zone, where the majority of these injuries occur. We find that that's going to be important again as we'll talk about some of the fractures that come through there. Then they start to calcify, and then you have the metaphysis. Additionally, there's the zone of Ranvier, which is a wedge-shaped group of germinal cells that adds circumference to the bone. Obviously, a young child's bones are going to add length, so they're much longer as they go through adolescence and into adulthood, but they are also adding circumference. So that's the zone of Ranvier that's responsible for that. Growth plates are really challenging, even in our pediatric world where we see a lot of kiddos, because they come and go at different ages, and it varies from child to child, and it varies from boys to girls. And so I don't put this up here for you to expect you to memorize all of these. I think it's helpful to understand that you're going to see these appear at different times. And then again, that's the upper extremity, both the appearance and then the closure of when the growth plates are going to go away. And same thing for the lower extremity, they're going to be different. I think this really helps with image interpretation. So you're understanding, when do I expect to see a ossification center? When do I expect to see a growth plate close? And sometimes trying to interpret pathology versus normal anatomy in these kiddos. We'll talk a little bit about this, but one nice thing is sometimes we have the availability of getting a comparison view. So if you're not used to looking at pediatrics imaging, and you're looking at an elbow, for example, it can be really confusing knowing what may be normal and what not. So sometimes getting that comparison view helps you say, oh, that is a normal ossification center there, and there's going to be some variation. So the general rule of thumb, which obviously varies quite a bit, still is girls' growth plates tend to close around age 14. Boys tend to close around age 16. As I said, there's going to be a range even within boys and girls. That some of these folks will have growth plates that are closed much sooner than that or much later than that. But I think it allows you to have a general concept of saying, if I'm seeing a boy who's under 16 or a girl who's under 14, I have to think about the growth plates. The growth plates are likely to still be open. That doesn't mean that when they're over that, they're all closed, or that this goes out of your differential diagnosis. But we often talk to our residents, always think about the growth plates first, and understanding whether that's an acute injury or overuse injury, where are the growth plates, and have that in your differential so we don't miss something. The apophyses in the pelvis or hip region, we'll talk a little bit about that as well. Those tend to remain open later than some of the longitudinal growth centers. And sometimes we'll see these in high school and early college age athletes as well. So there's two sort of basic types of growth plates, as I sort of alluded to earlier. There's the pressure epiphyses, which typically are along the joint surface or articular and are located at the end of a long bone. So for example, at the end of your radius, you're going to have a pressure epiphysis, the distal radial physis and epiphysis there, versus a traction epiphysis, which are typically more the apophyses, or slightly different can be the greater and lesser trochs, some of the tuberosities, epicondyles, and these are typically non-articular surfaces and are sites where muscles or tendons insert. Again, apophyses sometimes. One other aspect that's important for us to understand conceptually, because this helps us predict potential problems, but also changes our management, is understanding how much growth is remaining. We talked about when boys and girls may stop growing, but there's a lot of growth that comes and it's not uniform. And so even within different bones, so here's a figure demonstrating both the upper extremity and the lower extremity, what proportion of growth comes from the various parts of the bone. So for example, if we look at the proximal or look at the humerus, the proximal humerus provides a significant proportion, or 4/5 of the growth of the humerus comes from the proximal. So that allows us to tolerate a lot more changes or deformity to an injury to the proximal humerus than we might be able to in the distal humerus, because the body is going to grow and it's going to have some room for correction. That also allows us to think about is sometimes we have to worry, for example, when we look at the knee, most of our growth comes from the distal femur and the proximal tibia, so adjacent to the knee. And so if there is an issue there, there's still quite a bit of growth left, even though we may not think that they're growing much left. Most of the growth that's going to come is going to come from that area. So if you have a distal femur injury, then perhaps that's something we need to watch a little more closely. Although the remodeling potential and the ability to correct an issue is great, so is the issue for something to occur that may not be there initially, and we may need to follow that. When looking at this case, we're going to start kind of going through some case-based scenarios. I do have some questions built in throughout this lecture that we can get to the questions with the actual answers at the end, but there's some CAQ type questions that I did pull from the AMSSM Q bank to help prepare you for the types of questions they're going to ask on these topics in terms of the pediatric growth plate injuries. So our first patient is going to be a 12-year-old female soccer player who presents for evaluation regarding an ankle injury sustained when she was slide tackled during a game. She's having quite a bit of pain, unable to bear weight on her ankle, and the ankle is quite swollen and bruised. And obviously our differential is fairly broad there, but I want to draw your attention to the age. Oftentimes the CAQ is pretty good about trying to give us some clues in the question prompt. And so my differential is going to change a little bit with a 12-year-old than if perhaps I told you maybe this was a 17 or 18-year-old female soccer player. Because now, again, going back to what I was saying before, we're remembering, open growth plates. I need to include some growth plate injuries in my differential. And that doesn't mean it's always going to be, but we need to think about that. So the question is, which of the following Salter-Harris injuries is correctly matched with an accurate example, mechanism of injury, and the most common aspects of injury healing and prognosis? So sometimes they're going to ask you a little bit about the diagnosis. Sometimes they're going to ask you to understand the concepts. And so this one's going to go through 1, 2, 3, 4, and 5. And then it's going to give you examples of the fracture. And it's going to talk to you about whether maybe it's unstable or stable and whether it can result in growth arrest or not. So not only do we need to understand the types, but we probably need to understand their impact on growth, whether they need surgery or not, how they're treated. And so that's something that we're going to work through a little bit here. Growth plates, again, are primarily cartilage cells, and they are very susceptible to both acute and overuse injuries. We often will say that the growth plate is the weak link in the chain. And we do worry about the growth arrest or deformity with these. And so that's why oftentimes we want to make sure we're recognizing these injuries and appropriately manage them so we can minimize morbidity and get the athlete back to play, but hopefully prevent problems down the road. One analogy I will often use with my families is that of an Oreo cookie, and describing the cream in the cookie is similar to the cartilage in the growth plate. And so whether it's an acute injury and I'm pulling that cookie apart quickly, having a fracture, or whether it's more of an overuse injury where there's just a little gentle twisting on the cookie over and over again, that cookie's going to break in that cream. That's where the weak link is. That's where the physis is. So a similar concept is that chondral or cartilaginous layer of the physeal plate is more vulnerable, more susceptible to injury than perhaps the surrounding structures with the bone, which is very strong, or the stronger ligaments and tendons, versus that shifts, obviously, as the growth plates fuse. Now there are different weak structures into adults. So here's our case. This is our 12-year-old female soccer player who hurt her ankle, who's presenting for evaluation. And so here are a couple of the x-rays. We typically get 3 views on the ankle, and so I didn't include the 3rd view, but this gives you an AP and a lateral view. And you start to look at that, and hopefully your eyes will be drawn to this lucency in the distal tibia coming down and through here. And then if we look at the lateral view, now we can see it comes through the distal tibia and down into the physis and through there. So this would be categorized as a Salter-Harris type fracture. Salter-Harris is the most commonly used classification to discuss growth plate fractures. There's other conventions that are used too, but this is the most common and likely to be on the CAQ. It's 1 through 5, and a 1 goes through the physis and doesn't involve the metaphysis or the epiphysis. A 2 is going to go through the physis and exit out up through the metaphysis. A 3 is going to come through the physis and down through the epiphysis. A 4 goes through the epiphysis, the physis, and the metaphysis. And a 5 is what's known as a crush injury. 5s are very rare and somewhat controversial, so you're not as likely to see those. 1s do occur, also less common. No, type 2 is going to be the most common injury that we'll see. Now, there's a few things that we want to think about with these injuries that helps us understand both the classification as well as the risk. So the first thing I want to draw your attention to is where the fracture is occurring and whether it involves the joint surface or not. Because the 1s and the 2s, the fracture goes through the growth plate, but it goes away from the joint surface or does not involve the joint surface. And so a 3 and a 4 does involve the joint or the articular surface. And so for a couple of reasons, that's a problem. If they have involved the joint surface and when they're healed, if there's any sort of incongruity or step off or irregularity or a gap in the joint surface, it makes sense that that's going to cause problems down the road. Just from an articular standpoint, that's one of the challenges that we worry about. So 3s and 4s really need to make sure that they're reduced and heal well. The other thing that happens is we talked about the way that these injuries occur. They're going through the hypertrophic zone. Now, if a type 2, for example, is coming through the hypertrophic zone and exiting up through the metaphysis, so it's going away from the germinal layer of the epiphysis there, and the physis, and versus a 3 is coming through that germinal layer. So there's more of a disruption in the actual growth plate in a 3 and a 4 in the germinal layer, that growth plate is now potentially damaged and may not grow well. And we'll talk about that in just a minute as well. Additionally, the blood supply is disrupted in a different way. That epiphyseal vascular supply has also been disrupted. So there's kind of at least 3 things that are more concerning with a type 3 or a type 4 by coming through the epiphysis into the joint that raise the risk and should make us think twice about how the management and making sure that they're managed appropriately. Again, this is just a reminder on those zones and kind of looking at how the fracture is going to come. If it's coming through the hypertrophic zone and up away from the joint surface, then it's going to be potentially less damaging than if it comes through the resting zone of the physis there. This is a schematic sort of showing us what may happen. For example, with a Salter-Harris 2 that's coming up in figure A, you're seeing it's coming through the metaphysis, through the hypertrophic zone of the physis there, but the distal or the vascular supply of the epiphysis is not disrupted, and the germinal layer of the physis is not disrupted, typically goes on to heal fairly well. Versus if you have a Salter-Harris 3, comes through the germinal layer and disrupts the epiphyseal vascular supply. And so you may have AVN where there's not good blood flow there, or potentially you have what's called a bone bar, and the vascular supply has to come through a different area, so you can get a physeal bar where it doesn't grow. And then obviously if it's poorly reduced, you have a step off in through there. So this schematic's demonstrating some of those concepts that we reviewed. So a summary is 1 and 2s. Typically, they don't involve the joint surface, usually do well without surgery, are fairly stable, and are going to have a lower risk of growth, deformity, growth arrest versus 3s and 4s, involve the articular surface. I would encourage you to have specialist involvement unless you're managing a lot of pediatric fractures in your practice. That's probably orthopedic surgery or at least a pediatric colleague who manages a lot of fractures. I think would be a good consult for some of those more significant injuries. You're going to see a lot of these, especially in football, sports in general. We see a lot of fractures, and physeal injuries or growth plate injuries are very common and are a big source of all fractures in children. And we see a peak in adolescence. And despite the fact that we see lots and lots of growth plate fractures, growth deformity is a rare in less than 10% of all physeal injuries, but it does occur, and so we need to be aware of it. So this says impact of future growth. It could also be impact on future growth. Kids, because they grow very quickly, do heal faster than adults, and they have the potential to remodel. Younger kids or a younger, what we call skeletal age, allows for longer remodeling potential, and that's very helpful. Depending on the fracture location, also allows for better remodeling potential. There's what's known as Wolff's Law, which bones will remodel according to the stress. So depending on where the deformity occurs, there's more remodeling potential. So for example, in the femur fracture, where the knee articulates, a sagittal injury, a sagittal plane deformity is we can tolerate more than we can a coronal plane deformity, where we can tolerate very minimal rotational deformity because the bone can remodel those others much easier. Sometimes we will experience overgrowth after an injury, and then sometimes we will just experience more of a growth disturbance where either there's a physeal bar. So if we look here on the picture on the right, you will see a bar going across the distal radial physis where that growth plate that had been injured with a Salter-Harris 2 fracture several years, I'm sorry, Salter-Harris 3 fracture several years before, this growth plate, this bony bridge was formed. And so now there is ulnar variance where the ulna is longer than the radius. And so therefore, they went in and they resected that bar or took that out, and then ultimately had to come in and do an ulnar shortening or shorten the ulna to make them the same length due to symptomatic ulnar symptoms there. And so that can occur. That's something we watch for and follow them. And you can also have angular deformity if maybe one portion of the growth plate was injured and stops growing, but the remainder of the growth plate remains healthy. That can also cause problems down the road. I just want to make you aware of these types of fractures. I don't know that this will be a common question on the CAQ, but there are what are known as transitional fractures. The two most commonly referred to are what are called triplane fractures and Talot fractures. A triplane fracture is a combination of a 2 and a 3, and it's a three-part fracture that truly occurs in 3 planes in and around the growth plate. And then a Talot is a Salter-Harris 3. You can see the anterior tibiofibular ligament. It remains attached to a portion of the tibia and it will pull through. Now, these are called transitional fractures because they occur around the time where the distal tibial physis is closing. It's not completely closed yet, but it closes in a unique pattern that sets them up for this type of injury. So something to think about in our adolescent athletes as well. And then we're going to look at, so here's a CT showing a triplane fracture, some of the 3 planes that it's coming in. Here's a Talot fracture. And on the x-ray, you don't see much. You can see a very subtle lucency there, but when you look at the bone imaging, the advanced imaging, you can see there's a gap in there, and we would not want to leave that gap there. That could really cause problems, and so that needed to be reduced even, and so that one required surgery to fix that. So something to be aware of, look for on the x-rays. Coming back to our 12-year-old soccer player who had that Salter-Harris 2 fracture, typically these are treated with casting, whether it's the upper extremity or lower extremity. This one could be a short leg cast. You may make her non-weight bearing for a few weeks. There's going to be a lot of variation in duration of how long we're going to cast or make them non-weight bearing, but essentially we're trying to get that bone to start healing, then we can get them out, get them moving. If there's displacement, need to have that reduced, and making sure that we have adequate acceptable alignment, so to speak. And then we'll rehab them back, and oftentimes they can get back at 10 to 12 weeks to their sport and may consider a protective brace depending on the type of fracture, whether that might provide additional support and protection as they get back to their sport. All right, moving on to our next case. So this is going to be a 13-year-old football lineman, and sometimes our linemen are this size, but most of the time they're bigger. So that picture may not be representative of our actual patient here. But complaining of hip, thigh, and medial knee pain. No history of trauma. His mom reports that he's been limping. In the past couple of weeks, it's gotten worse. On his exam, you're noting that he has some discomfort with passive hip internal rotation. And when you try to flex his hip up, he has what we call obligate external rotation. He doesn't really let it come up straight. He likes to external rotate it, or the Draymond sign. And so that's demonstrating here on the right, this patient, when you flex their hip up, it's staying neutral. And on the left, when you flex it up, they obligately externally rotate. They do not allow you to keep it in neutral or internal rotation there. So in this patient, what is the most likely diagnosis? Is this septic arthritis, a transient synovitis, leg calvé-perthes, or a slipped capital femoral epiphysis, also known as a SCFE? And the second question, follow up from that, is now we've gotten some x-rays and we've confirmed what our suspected diagnosis was. What is our initial management of this condition? Are we going to restrict him from football until his hip feels better, send him for physical therapy, make him non-weight bearing and put him in a wheelchair or crutches, and consult orthopedic surgery for an urgent surgery? Or are we going to aspirate his hip and send the fluid for cell counts and culture? So I want you to think about what you would do in this situation and what your thought is with this particular patient. This patient that I'm leading you down the path has a SCFE, a slipped capital femoral epiphysis. They really like this one on the CAQ because it's not uncommon and because this is one we don't want to miss. It is a commonly missed injury, but it's not a good one to miss. So you want to have a high index of suspicion and a low threshold to pursue imaging of the hips, especially when you have an adolescent male, overweight or obese adolescent male with vague hip or thigh or groin pain, perhaps medial knee pain or knee pain, and you want to consider getting hip x-rays. It's more common in boys than girls, and the obesity itself can have some impact on the physes, both the mechanical effects of the extra weight on the bone, as well as the endocrine effects on the physeal chondrocytes. So this can also be seen in certain other metabolic or endocrine conditions as well, but primarily thinking about the obese teenager is higher risk for that. And this is a little bit of a unique one because this is one of the few sort of orthopedic urgencies that you may encounter in a clinical setting. These we do make the patient non-weight bearing, and we have an urgent orthopedic referral for stabilization of that growth plate. We'll talk a little bit more about that, but these are patients that we don't let them walk in our clinic. Once we've made this diagnosis, we don't let them get off the exam table and walk across the room. Most of the time, we don't put them on crutches. We send them with a wheelchair and plan for surgery the next day. So this is, again, a little bit of a unique one. Here's the x-ray of the patient zoomed in. We're looking at the right side here where you have the femoral head and the growth plate through there, and you have what's called Klein's line, where we're drawing a line up from the femoral neck, and it bisects the femoral head. When you look at the left hip there, that Klein's line comes up and it does not bisect the femoral head. So sometimes this is likened to the ice cream falling off of the ice cream cone. So on the right side, you have the ice cream and the ice cream cone, and the ice cream is sitting on the cone, versus on the left side, the ice cream is starting to fall off of the cone there. So you want to look for that on the x-rays. Typically an AP view of the pelvis and hips and a frog leg lateral of the bilateral hips is helpful. Sometimes it can be bilateral, and again, sometimes looking at what the other side looks like is helpful for you. But again, a low index of high index of suspicion, low threshold to get x-rays. These are typically pinned in situ, meaning that they'll put a screw in place. This is one of the times where the surgeons are willing to go across the growth plate with their hardware because that growth plate is already damaged. They're just trying to salvage the hip at this point and keep it from slipping further and trying to keep that epiphysis alive as best we can. Depending on the age of the patient and what things look like on the x-ray, they may consider putting a pin in the other hip, even if it has not slipped yet. And there's some different rules and thoughts on that the surgeon can help make. But sometimes we'll have that conversation with the parents as well. But this is typically a bit of a surprising conversation because the family comes in with just a vague hip pain, and the next thing they know, you're moving very fast, telling their kid's not going home and needs surgery tomorrow for something that, it's often a bit of a shock. And so again, getting x-rays, looking for this and thinking about it, but this is a very commonly tested topic as well. Our next case is going to be a 14-year-old male soccer player who's presenting with hip pain following a pop in his anterior hip while kicking the soccer ball during a tournament over the weekend. And when you ask him about it, he says, yeah, my hip was a little bit tight the past couple of days during the tournament, but I didn't think much of it. I was able to play, and then I kicked the ball, and I felt a pop and had immediate pain in my hip. So this is that patient. So what is your best course of action at this point? Are you going to order an AP radiograph of the pelvis to look for a bony injury? You're going to send him to physical therapy to address his strength and flexibility deficits, order an MRI to evaluate for a hip flexor strain, or ask his parents to leave the room and use open-ended questions to explore whether he wants to continue playing soccer or not. Um, again, yeah, the topic of this talk, growth plate injuries. I may be leading you down a particular example, but this patient has an apophyseal avulsion fracture, acute injury, but he's got an avulsion of his right AIIS, his anterior inferior iliac spine. So you can see that here on the X-ray. There's some asymmetry. I would encourage you to get an AP view of the pelvis. I think it's much more helpful. These can be missed if you order, say, 2 X-rays of the hip. If you order, right hip X-rays, they may miss it, especially if it's a little higher up, a different apophysis. The other nice thing about the AP of the pelvis is that it gives you a comparison. It allows you to see what the other side, the normal development, looks like on the contralateral side for comparison views there. So all of the apophyses in the pelvis are at risk of both overuse injuries, apophysitis, as well as avulsion fractures. So I have this figure here to help remind us of the more common apophyses that may be injured and the muscular origins or attachments. So the iliac crest, the ASIS, the AIIS, the ischial tuberosity, and the lesser trochanter are all commonly injured, and depends a little bit on sport and mechanism what you may see, but all of these need to be on our differential. Anytime that you have an adolescent patient who presents complaining of a acute onset of hip pain with or without a pop, oftentimes they will report hearing or feeling a pop, but they may not. But that acute onset, I want you to think about an avulsion fracture until proven otherwise. These are very commonly misdiagnosed as, for example, a hip flexor strain. And sometimes that's by a PCP or by an athletic trainer who's just not as familiar with adolescent injuries. And they will often start rehabbing them for 2 or 3 or 4 weeks. And maybe they start to feel a little bit better. The athlete tries to return to play. And then lo and behold, they pop it off again because they're trying to play through a healing fracture. And so early identification for these is helpful, allows for better rehabilitation and getting them back to their sport. So again, having this at the top of your differential in an adolescent athlete. Um,
Dr. Miller, can you go
yes,
back one slide just to point out something? So take note that there is like a normal little growth center right here that's on the inferior aspect, but that the avulsion is actually that part above. So if you just saw this right hip, you might be like, what's going on here? But on the left side, there's also a little growth center there, and that is normal. So
that's
always remember, look both sides.
very helpful. And these do ossify at different ages. And this is a little bit of a younger child. In this X-ray, if you look, for example, at their iliac crest apophyses, you can start to see them, but they're not fully ossified yet. And occasionally, in some of the younger teenagers, we will see these avulsion injuries with a fairly normal appearing X-ray because the apophysis is not yet ossified, so we can't see it on the X-ray. And you can pick those up on an MRI. And again, it still is an avulsion injury, but they've avulsed the cartilaginous or chondral apophysis as opposed. So, for example, in this patient, their ischial tuberosity apophysis is not very visible yet. And so that's something to look at. That's where that AP of the pelvis is really helpful to see what's normal for that comparison to the contralateral side, especially in the acute injuries. Thanks, Dr. Goldberg. Um, This is another common apophyseal avulsion fracture, just a different example. This is a left ischial tuberosity apophyseal avulsion fracture. You can see a large fragment that has been avulsed off there. That's from the hamstring origin. And so this is again a unique to adolescents. Typically, we'll see this here, similar to the hamstring injuries that you may see with some of the water skiers, or down in Texas, we think about Dak Prescott, who just had surgery for his hamstring avulsion. But the adolescents will see these ischial tuberosity avulsions. This was a study done in 2023 where they looked at hundreds retrospectively of pelvic avulsion fractures and found that about a third were the AIIS, a third were ASIS, and then another third were split kind of between the ischial tuberosity, the lesser trochanter, and then the iliac crest, lesser. But so you can certainly see it in all of them. Again, if you're, for example, seeing a soccer player, you know, the AIIS is probably more likely with that rectus femoris traction there, the repetitive kicking versus some of the other sports. We may see different areas. Dancers, I see a lot of the ischial tuberosity, or my gymnasts or dancers going into like a jump splits, for example, may have that ischial tuberosity from that forceful hamstring contraction. I think a lot of times these are acute on chronic injuries, meaning that there's probably been some repetitive traction from their athletic activity that has weakened that apophysis somewhat. They may or may not have symptoms prior to the actual acute event, but then sometimes that one event is sort of like the straw that broke the camel's back. That's enough to pull it off, and not always, but there's often some sort of prodromal symptoms, and it makes sense. They're super active. So these are almost universally treated non-operatively, and they tend to do very well with non-operative treatment, but they do need time. Again, it is a fracture, and that bone just needs time to heal. That growth plate needs time to heal. Sometimes we'll put them on crutches for a few weeks just until they can walk comfortably without a limp. I almost universally will send these for physical therapy to work on flexibility, mobility about the injured joint, and strengthening to try to help offload them so that they don't have recurrence of this, and we'll gradually get them back. Occasionally for really displaced greater than 2 centimeters fractures, or those who have not united and are symptomatic, we'll consider surgery. But a lot of studies have shown that they'll do fairly well, especially with the less than 2 centimeters of displacement. So I think if you have significant displacement or concern, always good to consult with your orthopedic colleague. But even then, they may still manage it non-operatively. And they do appear to do really well, despite the fact that they look bad on the X-ray and may heal, and still be able to see that injury. Most of them can do really well, get very strong back to their previous level of sport, and regain full strength. Okay, on to our next case. This is a 12-year-old male baseball pitcher presenting with right shoulder pain for the past month. He's playing on a travel team year-round. He throws multiple types of pitches, fastballs, curveballs, and he started learning a knuckleball from his pitching coach, who he works with twice a week. His dad is worried that his speed has been dropping. Dad brings his radar gun to the tournaments, and his son is just not able to throw as fast as he used to. And so that's probably why dad is there, is because his speed's not good. We got to get that speed back up. But the kid's kind of going on, my shoulder's been hurting. So this is a pretty common scenario in our clinic, and also common to be tested on. So what is the most appropriate next test in this young athlete? Are we going to do an ultrasound to evaluate for rotator cuff tendinopathy? Do we want to get x-rays of his bilateral shoulders to evaluate the proximal humeral physis for any widening or a stress fracture? Do we want to get an MRI to evaluate for a rotator cuff tear, or an MR arthrogram to evaluate for a possible slap tear? So here are x-rays that may be representative of a patient similar to this scenario here. And I want you to look at his symptomatic right side, the growth plate, compared to the asymptomatic contralateral left side that he doesn't use to throw. And there's several changes that you may notice in through there, but most significantly, you'll notice the widening of the physis itself is wider on the right. You notice a little bit of sclerosis and a little bit of fragmentation of the metaphysis, which are some changes we'll see on x-ray, as this has been a little bit more of a chronic injury there. Has been occurring over time. It's not typically one particular pitch or throw that's prompted this visit. But the fact that we're able to see some changes on the X-rays tells us this has been occurring for a while there. So this young boy has what's known as little league shoulder, proximal humeral epiphysitis or epiphysiolysis. And these are chronic changes. It's an overuse injury, common in the 11 to 16-year-olds. Most commonly we'll see in pitchers because they do the most throwing, but we'll also see it in catchers. We have a lot of patients that play pitcher and catcher, and those are the two positions on the baseball field that do the most throwing. But we'll also occasionally see this in other sports, volleyball players, tennis players, swimmers who do a lot of repetitive overhead activity and are stressing that growth plate. They will commonly have tenderness. This is one where I find it's really helpful for me to ask the athlete. I'll say, point with one finger to one spot where it hurts the most. And I'll do that on the knee, I'll do that on the shoulder, I'll do that lots of places. But this is one where they typically will point to their physis. Sometimes they'll almost draw a line right across their physis and they'll bring you right to it. They say it hurts here. And they have tenderness over that area. They often will have pain as well as weakness when you're doing resisted internal or external rotation, putting stress through that physis and putting torque through that. Sometimes also with empty can testing, they can have pain with lots of shoulder motions depending on how far they're progressed, but we can often reproduce it with resisted internal external rotation. Early on, their X-rays may be negative, especially if you have a family who's presenting early on and maybe not been pushing through it for a while. This is similar, but not to be confused with what's known as little league elbow. So little league shoulder, the proximal humeral physis, versus little league elbow, which is an apophysitis of the medial epicondyle. You have your flexor muscles and the ulnar collateral ligament that attach to that medial epicondyle. And with the repetitive throwing and valgus stress across that medial epicondyle, you can get apophysitis there. Sometimes we'll also get avulsion fractures of the epicondyle or of the ligament off of the epicondyle there. So medial elbow pain in a young baseball player or shoulder pain in a young baseball player should prompt us to consider a growth plate injury, little league shoulder or little league elbow. There are some good resources available to you. These are pulled from MLB, put together what's called Pitch Smart in conjunction with some other organizations, and these are available out there. And you can go onto the website and click on the age of the athlete, and it will give us recommendations for based on their age, the daily max number of pitches. So if I've got a 12-year-old, they shouldn't throw more than 85 pitches in a game. And if they've thrown 85 pitches or 84 pitches, perhaps they need 4 days of rest. And I find that a lot of times the coaches will follow the actual daily max because that's kind of a rule in the league. So they know to pull their pitcher out, but they don't follow the rest days. Maybe he pitches on Saturday and then Sunday he's back out there and he's catching in the game, or maybe Monday they're at baseball practice and he's throwing a bullpen session, or he's with, in the backyard with dad, or he's with his pitching coach. And so they don't always follow the rest recommendations. So it's important. And I think it's nice to have some resources that are something reputable to be able to share with your patients, that they'll look to, because everybody's kid's going to be in the big leagues at someday, at least in our clinic, they think so. And so that's that Pitch Smart USA Baseball. We want to shut these down. These are overuse injuries, and so that means no throwing. Sometimes I got to shut them down from hitting too. So if it hurts them batting or doing other things, I'll shut them down from that too. If it doesn't hurt to hit and it's just throwing, sometimes we can allow them to continue batting. But they have to not have pain anymore. They can't have tenderness there. We don't want to just cover this up with medicine. A lot of times they'll just be taking ibuprofen and playing through it, but that's not ideal. This is one of those injuries where we can have some active rest. We can continue to be involved in baseball in other ways. They can work on conditioning, they can work on fielding, running bases, and they can do rehab of their core, work on flexibility, hip flexibility, core strengthening. And then we'll rehab back around the shoulder once it feels better. But sometimes we have to just let them rest a little bit before we even start strengthening around that shoulder, or else we'll just be beating up on that injured growth plate, trying to do rotator cuff strengthening while that growth plate's injured. And then eventually, once they've gotten their strength back, we'll take them through a interval throwing program. Again, on that same website from Pitch Smart, there's access. This is an example of a throwing progression for a 12-year-old little league player. It's very nice to be able to have the family kind of go through this. Throw a day, rest a day, throw a day, rest a day, throw a day, rest 2 days. And then week 2, do a little bit more, throw a little bit more, a little further back and progress them back. We're monitoring for symptoms. We're allowing the body to acclimate to the load again and be ready to participate at a higher level as they progress. Moving on to our next case is case 5. This is a 13-year-old boy presenting with gradual onset of anterior knee pain. It's worse when he's running and jumping and kneeling or when he bumps it. He doesn't really remember having any injury. And he has some swelling and tenderness overlying the tibial tubercle. So what does he have? He has Osgood-Schlatter's, very common, and this is one that also they like to test on, but it's very common type of injury. This is a traction apophysitis. Typically, the extensor mechanism or the patellar tendon from the quad will pull and tug on the tibial tubercle at the anterior tibia there. We see this a lot in running and jumping type sports. It's more common in boys than in girls. Can be bilateral, sometimes it's unilateral, and typically gradual onset. I do want you to differentiate this from sort of the sudden onset because they can also have avulsion fractures. All of these apophyses, they can have apophysitis or avulsion type injuries. And so your history is going to be really important, that clinical history of was there a particular event? Did something happen? And again, sometimes maybe they had some soreness for a while and then there was still an acute event. So, for example, maybe I've had Osgood-Schlatter's for a few months, 6 months, and all of a sudden they were running down the basketball court and planted their foot to go up for a layup and had immediate pain and swelling in their tibial tubercle. Well, that's no longer Osgood-Schlatter's. Now they've got an avulsion fracture there, and that needs to be managed very differently. So again, asking your history and going through that differentiating is really helpful. Oftentimes they'll have tightness, whether that's their quads, their hip flexors, their hamstrings. We'll notice some inflexibility. As these kiddos are growing, their bones are growing faster than their muscles will, so they become relatively inflexible during these growth spurts. In addition to the fact that there's rapid cell turnover in that apophyseal plate, and that hypertrophic zone is vulnerable to injury, increases the risk of both apophysitis or avulsion type injuries. So again, they typically have pain and swelling over their tibial tubercle and point tenderness right on that spot. Sometimes they don't like it when you flex their knee all the way up because you're putting tension on their quad. They'll feel that a little bit. You can certainly get x-rays, AP and lateral x-rays of the knee if you want to kind of confirm, but most of the time, if it's a kid who's coming in without an acute event and just sort of insidious onset and their exam is otherwise reassuring and benign and they have just localized tenderness of the tibial tubercle, you may not need to get x-rays to make a clinical diagnosis of Osgood-Schlatter's. As an example, is one of those where you sometimes walk in the room and you can see the bump across the room and you say point to where it hurts. When they point to the bump and that's the only spot that's tender, you can feel pretty comfortable that that's going to be Osgood-Schlatter's. But there is an x-ray showing what you may see. Sometimes you'll see some swelling of the tibial tubercle. Sometimes you'll see fragmentation of the apophysis and some thickening of the distal patellar tendon as it attaches into the apophysis or the growth plate in through there. And it may not look too different if they've had an avulsion injury. Sometimes, again, swelling and some fragmentation through there. So that's where your clinical history is really helpful. And then if you're worried that they have an avulsion fracture, having them perform knee extension while seated. So the way that this patient's sitting here, have him straighten his right knee out all the way, firing that quad and make sure he can get to full extension. And then also when they're laying supine, you can have them lift their leg, an active straight leg raise, and watch for any sort of extensor lag where they're having a hard time getting that extensor mechanism going. But again, that history is really helpful. So, so this boy has coming back in, as we talked about. He's having pain. What do we think he has? So that's a Q-bank question. Does he have an avulsion fracture? Does he have a Sending Larsen-Johansson? Does he have Osgood-Schlatter's? Does he have Iceland's disease? They like to throw in eponyms and different names, or patellar tendonitis. And so now, same patient, the x-rays we've got show fragmentation at that inferior pole of the patella, so slightly different patient. Now, instead of the tibial tubercle, I've switched it on you and told you that now the fragmentation and the tenderness is as the inferior pole of the patella. So this is a slightly different presentation, but same concept. So we're going to ask what we do with that. But that patient may have what we call Sending Larsen-Johansson syndrome. This is kind of like the The little sibling of Osgood-Schlatter's, slightly younger kids than the Osgood-Schlatter's. As you can see on the X-ray here on the right, that patellar apophysis is where the symptoms are. The tibial-tubercle apophysis is just starting to ossify. You can see a little bit of an ossification center starting there, but it's still mostly cartilaginous. So that's oftentimes why we'll see SLJ just a little bit younger than the Osgood-Schlatter's. This is less common than Osgood-Schlatter's and sometimes more difficult to treat. So if you're seeing this, you can certainly be a little bit more, I guess, aggressive in our treatment early on, or refer them on if you're not comfortable managing this in a younger kiddo. Both of these, Osgood-Schlatter's and SLJ, spend a lot of time reassuring the family and educating them on the diagnosis and what's causing the symptoms and what to expect. We will commonly see that they've seen their pediatrician or their PCP who may suspect the right diagnosis and then shut them down for 6 weeks. And lo and behold, their symptoms get better while they're resting for 6 weeks until they go back. And then the symptoms return again. And so letting them know that this may come and go while they're actively growing in that area. Our goal is to manage their symptoms so that they can stay active. We don't want to just cover it up with pain. Sometimes a patellar strap or a knee sleeve or something might help with some discomfort. And we want to do a lot of flexibility for them. But I think that's helpful for them to understand that it's safe to play through a little bit of this if they're not having a lot of discomfort and they're not limping, and to be aware of the potential for a avulsion fracture. Sometimes we'll send them to physical therapy, and then some studies have shown that you may consider prolotherapy or hyperosmolar dextrose injection for recalcitrant cases. We don't want to do any steroid injection in that area as well. Occasionally, these kiddos will go on and have a small piece of bone or ossicle that stays. They become symptomatic as they remain symptomatic as they move into adulthood, which is occasionally sent for excision with the surgeon. One thing that we will see, so sports like volleyball or football where they're landing on their knees a lot, it's a pretty sensitive area. So if you're barely touching the tibial tubercle and it's so sensitive they're jumping off the table in the exam room, a knee pad is probably helpful. Sometimes they can cut a little hole to over that area there, and then restrict them if they're having a tough time. Gets better after a couple of years, but some patients may have problems into adulthood. All right. Moving on to our next case. This is going to be a 9-year-old football player who comes in. He's been having heel pain for the past couple of months. Hurts mostly when he's running and jumping, worse in his cleats. His mom notes that he's limping each time after she picks him up from practice and games. So this young boy has Sever's disease. This is calcaneal apophysitis. This is an apophysitis where the Achilles tendon and the calcaneus attached there. You have kind of that growth plate in the heel is getting hit from both directions. It's getting traction from the Achilles tendon, and it's getting kind of impact from below as they're hitting and running. Cleats don't tend to have much padding, and barefoot sports like gymnastics, there's no padding there. So soccer, baseball, football players, and gymnasts will see this. Typically 9 to 12-year-olds, maybe bilateral, and this also tends to get better. This is another one of those where it's safe for them to push through some discomfort as long as they're not limping or having a lot of pain that's changing their gaits or their ability to participate. If it's a little sore, it's okay for them to push through that. There's an example. Sometimes we'll see some fragmentation of that calcaneal apophysis. Sometimes it'll be kind of sclerotic or white, and through there, but they typically, again, will point and show you. If you ask them to tell you where their pain is, they will sometimes draw a circle exactly around their calcaneal apophysis and tell you that that's where it hurts. This is really common. Probably almost every soccer team in this age group, there's probably 1 or 2 kids dealing with some Severs. Pretty common there. Here's a schematic showing you both the Achilles tendon traction along that apophysis, and again, also you get the impact underneath. Also on this figure, you'll see the apophysis at the base of the 5th metatarsal. We'll talk about that in just a second. Treatment for Severs, we call it Severs. Sometimes it's Severs, but when you're talking about Severs foot, sometimes patients look at you funny. So Severs or Severs, calcaneal apophysitis. We'll use heel cups. Cushioned gel heel cups tend to really help protect that from impact, lets them feel better, have them put it in their cleats, have them run, playing their different sports. I don't recall if I put a picture in here. There's also what are called cheetahs for barefoot sports like gymnasts. that are basically a neoprene sleeve with the heel cup sewn onto it that work fairly well for a barefoot athlete, taekwondo, or gymnastics. Um, Again, relative rest, get them doing some Achilles stretching, especially if we feel like that Achilles is contributing to the injury or symptoms. Try to avoid going barefoot even around the house, just a good, comfortable shoe. And same concept as the Osgood Slaughters, reassure them that this is okay and educate them on what to expect with the symptoms coming and going for several years while they're actively growing in that particular area sometimes is very helpful. So I mentioned that apophysis at the base of the fifth metatarsal. There's another similar less common, kind of like Osgood Schlatters and Sending Larsen-Johansson. There's Sievers, and then there's Iceland's disease. This is apophysis of the base of the fifth metatarsal from the repetitive traction of the peroneus brevis. More common in dancers or ballet who are going up on releve and sometimes up on point even at this age. And more lateral foot pain, focal tenderness over the base of that fifth metatarsal. But again, just like the others, you want to differentiate this from an acute avulsion type injury, apophysitis versus an avulsion. So I think that's a common theme for all of these is a good history and trying to, your clinical pathway is acute versus sort of insidious or chronic onset of symptoms. Our next case is going to be an 11-year-old female gymnast presenting with wrist pain. She trains approximately 30 hours per week and is complaining of tenderness over her distal radial physis. She also has pain with wrist extension on exam. So I talked about how many hours she's participating. That is a very normal number for us to see in some of our young gymnasts, but it's a lot. Sometimes there's been some thought that training more hours per week than your age is a significant increase in the risk of overuse injuries. So an 11-year-old, 11 hours per week, she's 3 times that. And so we'll sometimes use that. Now, gymnasts, it's a little bit hard because they do train a lot of hours, but the more repetitive activity, especially on these open growth plates, increases the chance of an overuse type injury. We like these sport-specific injuries. You got little league shoulder, little league elbow, and the baseball players. This one's gymnast's wrist. So common in our gymnasts, sometimes see in our cheerleaders as well, do a lot of tumbling, also known as distal radial epiphysitis and related to repetitive loading. Very common in our gymnasts. We'll see this quite a bit. Again, as the hours go up, so does the risk of this. X-rays may be negative, but similar to our other x-rays, we can see some findings including widening, sclerosis, or fragmentation. So here's an example of a left symptomatic distal radius with a lot of widening and irregularity. That's a pretty sick looking growth plate. Excuse me, but it's pretty common for us to see growth plates that look like this on x-ray. So we do tend to see them. This is a pre-treatment and post-treatment x-ray. I'm sorry, no, this is a comparison x-ray. In a gymnast, this may or may not be helpful because they're typically tumbling on both hands. And so sometimes you will find an asymptomatic gymnast wrist on the opposite side. But this is a fairly healthy appearing x-ray of the growth plate on the right side with a pretty sick left-sided distal radial epiphysitis, and it should look more like the right. Similar to the patient that had the physeal bar, we occasionally will see if they've pushed through this for a long time that you'll have growth delay or growth disturbance of the distal radial physis, which leads to ulnar variance, where the ulna grows longer than the radius. And so then we'll have them come in with symptoms related to their ulna and have to have an ulnar shortening. So there is potential morbidity associated with ignoring this and pushing through that. Similar to the cheetahs, another feline, the tiger paws for the wrist are an example of a brand of wrist supports that can be used for cheer or gymnastics to help protect that growth plate. Sometimes either before they get injured or after they go back, provide a little bit of additional support across that physis for them. Our next case is going to be case 8 is going to be a 15-year-old female cross-country runner who presents with left anterior hip pain radiating along the lateral to posterior hip. Started gradually, worsened as the season goes on. Sometimes hurts when she coughs or sneezes. Has pain primarily over the anterior and mid-iliac crest and has pain with resisted hip abduction. So what are you most likely to see on x-rays of her hip and pelvis? Are we going to see an avulsion fracture of the ASIS, widening of our left iliac crest apophysis, a skeletally mature pelvis with no apophyses at age 15, or are we going to see a femoral neck stress fracture there? So this patient has apophysitis of her pelvis. Just to briefly touch on this, similar to all the other apophyses, the repetitive traction, we mentioned this earlier when we were talking about avulsion fractures. Very common. These are a little bit different because they're not as much healing time, relative rest, warming up and stretching. Sometimes we'll do some physical therapy and ice after activity. So a very common injury, a little bit less concerning than the avulsion fractures. So here's my fun little figure to remind us of some of the things that we may see as we go down the body. And pretty much any body part, there's open growth plates. You want to think about the different types of potential overuse injuries. These are the overuse injuries that I'm highlighting here, in addition to the acute injuries that we highlighted. So that's the end of my presentation. I do have some CAQ questions prepared. I don't know, Dr. Goldberg, if you'd like to move to the CAQ questions, or how you'd like to proceed here.
Why don't we just take about 5 minutes and do the CAQ? I don't want to run too much over, but I think they
Perfect.
can be very helpful.
Yep, perfect. Like I said, these are from the Q Bank, so I think are kind of high yield questions. Um, so our first question here is, again, back to the Salter-Harris injury. So we went through these. These are the same questions we kind of went through, but we're going to go through them now. So type 1. So the question is, what type of Salter-Harris and what match it with the right? So type 1, distal fibula physis present. Andy, did you want to do the survey? Very good. So yeah, the answer is B on that one. And I actually did. If some of you have been studying the Q Bank already, E was the correct answer on the Q Bank question, but I switched it briefly. So I'm very observant if you'd practice this question. But type 2 fractures, they extend proximally away from the growth plate. I'm sorry, away from the joint surface, typically heal well and don't affect the growth. Okay, question 2. A 13-year-old football lineman complaining of hip, thigh, and medial knee pain, limping. What is the most likely diagnosis? And we'll keep moving. Very good. Yep, Skiffy. So always want to think about Skiffy in this, and we'll go on to the next question follow-up of that. So we've got the X-rays, and what is our management going to be of this one? Great, y'all got it. Yeah, this is one of the few ones where the jump to surgery sounds like a pretty extreme example, but sometimes they're going to be testing you for urgencies or emergencies that they want you to recognize and make sure that you're responding appropriately. Question 3, 14-year-old soccer player popping his hip. What is our best course of action? Great. Looking good. Yeah, we want to get some x-rays. And again, it's an AP of the pelvis, not hip, so that we can look for a bony injury. Always think about a growth plate injury, an avulsion fracture, and an adolescent athlete with a pop and pain in their hip until proven otherwise. Next one, 12-year-old baseball pitcher presenting with shoulder pain times a month. What's the most appropriate next test? Correct. Now, I will have a caveat on this one. I don't always order bilateral or comparison x-rays. We typically start with just the single injured side because we're pretty comfortable at looking at the growth plate and can identify without having to get x-rays of the other side. The answer for this question was bilateral, and it's helpful to have the comparison view, so I left the question as it was. The next one's a 12-year-old basketball player with 3 months of anterior knee pain, tenderness over the inferior pole of the patella. What is our diagnosis? Correct. So Sinding Larson Johansson. Now they can have a patellar sleeve avulsion fracture at the same spot. They can pull off that apophysis as well. So again, differentiating acute versus chronic injury there. And now, which of the following is the best treatment for this patient? So same patient, what's the treatment going to be? Correct. So sometimes they are going to assume that you have the diagnosis, and so they're making you jump ahead a couple of steps. They may give you information, and you're like, "Oh, I know what this is. I know that this is Sinding Larson Johansson syndrome." But then they're not going to ask you, "What is it?" They may say, "How do you treat it?" Or what's the next test that you have to order? So you have to make that next step. 15-year-old cross-country runner with the hip pain. What are we going to see on her x-rays? All right, widening. And that's where that asymmetry is really helpful, getting the AP of the pelvis, looking at both apophyses. All right, that's the last question.
Thank you. That was awesome. What a great overview. And I liked the case presentation, all the questions. So thank you, thank you, thank you. And this will be posted to our channel and should be able to be found for people to see in the future.
Thanks so much. Have a good night.